Good evening, everyone. Welcome to the Behavioral Health Workforce Education and Training Interprofessional Integrated Health Education Series on today, September 20th, 2022. This program is supported by the Health Resources and Services Administration, HRSA, of the U.S. Department of Health and Human Services, and all of our grant numbers are listed for your review. An overview of tonight's agenda. I am Dr. Katherine Y. Brown. I will be serving as your moderator. We will have a welcome by Mr. Ross Fleming III, Director of Behavioral Health Practice at Meharry Medical College. And tonight's presenter is someone who has been here before, and you are in for a treat with Dr. Eboni Winford, Director of Research and Health Equity at Cherokee Health Systems. Next slide. A gentle reminder, please keep your microphones on mute during the presentation and use the chat box for questions and comments. At this time, we invite all of you, please type your name, your organization, your city, and your state so that we can know who is here with us virtually. Let's connect on social media. Please follow our Twitter page at PCTCOP and use the hashtag PCTCOP. I know that you are going to hear something amazing tonight, so think about it. We also invite you to share your Twitter handle in the chat box, and we will be sure to follow you. Save the date. Tonight's presentation is part of our BHWET Interprofessional Integrated Health Education Series. The next date will be October 25th, 2022 with Dr. Andre Churchwell. For more information, we have listed all of our websites. The website for BHWET, meharrybwet.org, our TNAHEC, which is tnahec.org, the National Center for Medical Education, Development, and Research, ncmedr.org, and also our college-wide patient-centered medical home, which is cwpcmh.org. Now, meet the team. We work under the leadership of Dr. Patricia Matthews-Juarez, who is in the chat with you all tonight. I am Dr. Katherine Y. Brown. I'm an assistant professor in the Department of Family and Community Medicine. I also serve as Director of Communities of Practice and Dissemination at the National Center for Medical Education, Development, and Research at Meharry Medical College under the leadership of Dr. Patricia Matthews-Juarez and Dr. Paul Juarez. Meet our psychiatry team. They're all listed. Also, our team at Family and Community Medicine. We have our TNAHEC and our BHWET administration. At this time, I'm excited to introduce Mr. Ross Fleming III. Welcome, Mr. Fleming.
Good evening, everyone, and welcome to the Behavioral Health Workforce Education Training Lecture Series. I'd like to welcome everyone that's in the room today. If y'all can clap and raise your hand, say hello. We got 12 people in the room right now with us right now, so I'm so excited about that. And then we have 31 out there in the Zoom land, right? 46 people out in Zoom land right now. I'm so appreciative of you guys following us today. So tonight's topic is the integration of mental and physical health, making the mind and body connection. This is being offered through a collaborative effort. Through an integrated health approach, the Departments of Psychiatry and Behavioral Health Sciences and Family and Community Medicine have collaborated with Tennessee area education centers to train residents, student scholars, and other health professionals to work with persons in rural, vulnerable, and medically underserved communities. This approach will expand the number of behavioral health, family medicine, and other professionals who will stay and work in primary care settings in Tennessee, as well as in rural, medically underserved communities nationwide. Tonight, we have an opportunity to expand our residents, student scholars, as well as others training as we hear from an expert in health equity. I hope you will listen and engage in this very important topic tonight. And right now, I'd like to introduce you to my colleague, who's going to be introducing our speaker this evening, Natasha Yoakley.
Good evening and welcome. Eboni Winford, PhD, MPH. Dr. Winford is the Director of Research in Health Equity and a licensed psychologist at Cherokee Health Systems in Knoxville, Tennessee. Dr. Winford is the clinical lead for CHS's Consultation and Training Program, which provides individualized on-site training to other primary care organizations as they seek to integrate their practices. She oversees research initiatives, including those funded by the HRSA, the Tennessee Department of Health, and the National Institute of Health. She holds membership roles in organizations such as the Collaborative Family Healthcare Association, the American Public Health Association, and the American Psychological Association. Additionally, she serves as adjunct faculty in the Department of Family and Community Medicine at Meharry Medical College and a part-time lecturer in the Department of Psychology at the University of Tennessee, Knoxville. Dr. Winford earned her doctoral degree in clinical health psychology from the University of North Carolina at Charlotte and a Master of Public Health from the University of North Carolina at Chapel Hill. She is a proud life member of Zeta Phi Beta Sorority Incorporated. At this time, I would like to welcome Dr. Eboni Winford.
I'm going to share another updated version of these slides that I literally just finished like 3 minutes ago. That's why I logged on as late as I did, because I was adding some updates. So I'm going to stop sharing this one and then get the most recent hot off the presses version of the presentation for tonight. So hello, everybody. I'm excited. I think this is like my third or fourth time being able to speak with you all. So it's a privilege to be able to be invited back multiple times. Dr. Brown said that she was incredibly excited for me to speak. So I just want to say no pressure for me like to do awesome or anything like that. But one thing that I do enjoy is the topic that we'll talk about today. I have become very fluent at chat boxing while also communicating via Zoom and sharing the slides. So please don't hesitate to put your comments, questions, or concerns in the chat box as we go along. If it's relevant to like the slide that I'm on, I'll go ahead and address it. If not, we can hold it to the end, okay? So I want to go ahead and give you the title. We're going to talk about the importance of integrating the mind and the body, physical and psychological health, because last time I checked, we weren't just one or the other. Both things interacted to impact our wellness and our well-being. The other caveat that I will give you all, I don't think everybody knows this, but 4 weeks ago yesterday, I had a ginormous surgery. So I was cut from my sternum to my pelvis, and so I'm still recovering my stamina and my breathing. So if I pause, take some water, like just give me a few seconds, I'll keep it moving. I've been doing okay so far, but again, just want to give you the heads up if something seems a little bit funky. But I'm well, and I don't look like what I've been through, so I'm good, okay? All righty, so here are the objectives. I want to make sure that we know the importance of integrating behavioral health and medical health. Talk about some coping strategies that we all can use, particularly as organizations and as systems, to cope with the stressors that life has brought along this year. And then again, just understand the importance of the team when we're talking about integrated primary care. So that team focus was kind of the piece that I wanted to add in, as well as some additional information about health equity and root causes. And so again, please use the chat box. All righty, so I like to get us all on the same page. I never want to assume that we are coming from the same perspective, and I never want to assume that we are all using the same language. So this will be the only slide I read to you mostly verbatim, and I'll give you the history before I do that. So I've been saying this word integrated care, this term integrated care. I've said it a couple times since I started, and I've been speaking for less than 5 minutes, but I've said it a couple times. If I were to ask all 49 people who are on Zoom plus the 12 people who are in the room to define integrated care, I would get 61 different definitions of integrated care. So imagine what's that's like if you are a pharmacist or a behavioral health consultant or a psychologist therapist or a primary care provider or a gynecologist or an insurance provider or, a front office person or a biller and coder. You probably have 30 million different ways to understand integrated care. So it's hard to all be on the same page if we don't have a shared lexicon. So that's exactly what happened back in, I think it was 2012, 2013, a group of experts were literally in a room for a weekend, and they only left to pee and to go to sleep and come back again. And seriously, they were locked in with consent, and they weren't allowed to leave until they had created a shared definition of integrated care. And this is the result. And the idea was that, all right, if we have this shared definition, no matter what team member is working with us, no matter, what discipline you come from, what training you have, you will understand what I'm talking about when I say integrated care. So again, this is the only one I'll read mostly verbatim, okay? So it's the care that results from a practice team of primary care and behavioral health clinicians who are working together with patients and families, using a systematic and cost-effective approach to provide patient-centered care for a defined population. It may address mental health, substance abuse concerns, health behaviors, life stressors and crises, stress-related physical symptoms, and ineffective patterns of healthcare utilization. I like to highlight a few words that have pretty much every single text manipulation possible. You got some underlining, you got some bolding, and some italics on 5 different words/phrases. And I just want to highlight a few. Team, that's the coolest part about integrated care. The patient is not my patient, it's our patient. So that means I get to celebrate in the patient's successes and scream and pull out hair when things aren't going the way that we want it to go, or if the patient is experiencing setbacks. It's shared setbacks. We all get to contribute. The patient-centered piece, one of my favorite things to highlight is that the patient is the most underutilized member of the primary care team, the most underutilized member of the whole healthcare system in reality. This model that we're talking about, when we bring multiple disciplines, multiple expertise levels and people and trainings together to take care of like one person, that centers the patient, centers the person, reduces the barriers that people typically have to face when, we recommend all these other, disciplines and experts, but we don't really take into account the fact that for every additional appointment we ask a patient to attend, we're asking them to make one additional change. So it might mean missing one additional day of work when they may only work hourly. It may mean asking them to find additional childcare when they barely got the childcare they have. So we want to center the patient, and that's why this model works really, really well. We revolve around the patient. They are the center and they are the most underutilized member of this whole team, but this causes us to reflect on that. Okay, so in order to truly get to an integrated care type of experience, you have to have organizational, functional, service, and clinical transformation. It's not something like you just woke up like this. It doesn't work that way. It's been likened to learning to ride a backwards bicycle. Like most of us learn how to ride a bicycle, but there was actually a bicycle that was created where when you turn right, the wheel goes left, and when you turn left, the wheel goes right. And the person who created this bicycle over 8 months was able to learn how to ride the bicycle backwards, but it took trial, it took error, it took innovation, it took creativity, it took some skin knees before he was able to do that. Same thing with any type of transformation within our healthcare system. It's going to take trial, error, tears, some sweat, drop of blood here and there in order to fully transform these domains that allow us to center the patient and all of the concerns they bring with them when they walk through the door. So when we think about integrated care, we have to think about functions of primary care. So for me, I work in the primary care office. I work with FNPs, MDs, DOs, bachelor's level case managers. We have MAs, medical assistants, licensed professional nurses, RNs, like whole 9 yards. Everybody's in there with me. But we are all primary care providers. No matter what our licensure is, no matter what our training is, we are all primary care providers, and we're all working together to meet these goals here, which is contact. We want them to come to us first. A cool part about addressing mind and body in primary care is that if a person shows up with a skinned knee, I can also talk to them about stress management while they're there, because they came to their primary provider and we met their needs while they were already there. It's comprehensive. So I don't get to say, oh, that's not my job, or I don't know how to do that. I can't do that. Yes, I do. I know how to go to Dr. Google or somebody that's credible and find a way to say, absolutely, I can help you with that. Because primary care is primary, right? Most things come through that door. It's coordinated, meaning we talk across the disciplines. We talk across team members. And again, we're centering the patient in the middle. And it's continuous. We get more than one chance to take care of the patient, to meet them where they are. And we note that because it's continuous, we get to accept that patients are going to leave our offices doing the exact same thing they were doing when they got there. And that's okay. It's not your fault. Doesn't mean you failed. It means you get another chance to chip away at that motivation and change. So these are the things we have to continually keep in our minds as we're blending our different worlds together while centering the patient in the care. And one of the biggest reasons why we got to do this is that, you know, when you think about people who meet criteria for DSM diagnoses, I think this source is from 2019. We don't have too much additional data. I mean, because COVID ruined everything, right? But most people who have stress or mental health related concerns don't go see a psychiatrist first. They don't go see a therapist first. They go to their primary care provider and they say, hey, doc, my head hurts. Or hey, doc, my stomach hurts. Or hey, doc, my chest hurts. However, what I've learned and what the research tells me, and I want you all to use a chat box to tell me if I'm wrong for your perspective, but most medical training does not teach the severity and the breadth and the depth of behavioral health and mental health knowledge that you need to be successful when 70% of the people who meet criteria for DSM diagnosis come to you first. Okay. And so the importance of having behavioral health, mental health providers in the primary care setting is that that's all I went to school for. And so we can work together to center the patient and their needs. Okay. So they're coming to us because we're their primary care providers. And oftentimes patients get referred out because the expertise isn't there. The team may not be as strong as it could be, the different levels of expertise and disciplines. But that's why we do it together, because the patient shouldn't have to go to 3 different appointments just to address depression. Okay. And so when we think about how do you do this well, so that way you can take care of the medical component and like the mental health component. And I just want to be clear, for me, health is health, right? Like I don't always talk about mental health, medical health as though they're separate, because health is health and they are so interconnected and like married to each other that it's hard to say where one stops and one ends. So we're thinking about health when we think about this. But when we think about integrated health or behaviorally enhanced health, we want to think about who plays a role on the team. And so you've heard me talk about team members before, but we have a primary care behavioral health person. For us, we have a consulting psychiatrist. So again, our goal is to be contact first and comprehensive. In primary care where I work, most of the primary care medical physicians or nurse practitioners, they prescribe our psychotropic medications. And it's not because necessarily they want to, right? But let's just be real. We don't have that many psychiatrists coming out of residency anymore. And 70% of the people who are meeting criteria for DSM diagnoses are coming to their primary care provider. If all 70% were to try to go to psychiatry, they wouldn't get in until next year sometime. So we have to enhance the quality of the care we give when the patients are there. So where I am at Cherokee Health Systems, we have a psychiatrist we can call anytime. I could literally call him right now. I won't do it, but I could call him right now and say, hey, I have this patient who has failed sertraline. We've gone from 50 to 75 to 100 to 150. She states that she's taking it every single day, reporting the following symptoms. Labs are the following. What are your recommendations? And they might say, why don't you try venlafaxine? Or something like that. No, I'm not licensed to prescribe medications, but because I work in primary care, I know what medicines get to go. Okay. But again, my care and my knowledge is enhanced because I'm working on my team. So I get to take care of the patient better. All of the patients that we see in integrated care are my patients. Cherokee Health System saw 70,000 patients last year. That means I had 70,000 patients last year. No, I didn't see them all, but because we share the whole care, they were all mine. So if any one of those 70,000 walked through the clinic and they had a need and I was available, then yeah, you're my patient now. Come on through. I have nurses. I have front office staff. I have medical assistants. Like all the staff that's in the clinic, we share it. They call me their BHC. I call them my nurse because we're all part of the same thing. And every team member has a role to play. They can help us identify and understand from their own unique perspectives, like what might be contributing to the distress that the patient is endorsing on that day. For me as a behavioral health provider, I consider it a failure if a patient comes into the clinic and has a mental health need and I can't take care of them on the day that they're there. If I have to refer them out or get them an appointment on a later date, then I consider myself having failed that patient. The patient population I work with, most of them are at or below the federal poverty line. And again, I don't know what it took for them to get to that one appointment today. So I will move mountains to make myself available for somebody while they're already in the clinic, instead of asking them to endure another burden of coming to another appointment. If I can just flex myself and make myself available to them. We work together to take care of medical conditions, all health-related conditions, the DSM conditions, the ICD conditions. We work together as a team to address them, and we are really good about acknowledging how they each influence the other, and how if we don't take care of one, it's going to be hard to take care of the other. One of my favorite examples of that is that this took me a minute, y'all, so I can only share this like in excitement, like maybe a long time after I was actually successful. But I had a colleague who would tell somebody who had diabetes and was also consuming alcohol, if you come back sober, then I'll refer you for, I'll start you on a medication for your depression. And I looked at that provider sideways like, that don't sound right. I was like, I want you to replace sober with controlled diabetes. If you come back with your A1C less than 6, then I will treat your depression and by giving you a medicine. Like, how dumb does that sound? And it did sound dumb. And I like to think of that in the same way. We can't just pick and choose what we're going to address. One is not more important than the other because they connect to each other. And when you put those disciplines in the same situation, in the same space, we're reminded that we can't tell somebody to come back sober to get treatment for the thing they came for treatment for today. Okay. And for me, I write in the exact same medical record that my medical colleagues write in. I read their notes. They can read my notes. There are no glass walls. And some people cringe when I say I'm a psychologist and people can read my notes. It's like, ooh, scary. Have you ever read one of the notes that y'all write if you're a medical person talking about the abscesses in all the parts of the bodies, but we get scared when somebody says they have trauma and we read that? Like, we got to fall back, because in our best intended efforts to destigmatize mental health, we stigmatize the crap out of it by putting all these barriers and guidelines to notes and access and records. Like, it's not spooky deep, it's health. And we have to learn to recognize health for health. Okay. So this is how we emphasize that shared mind body thing. Here's some things that I typically do on my team to help address like the mind component of the mind body thing. And you'll note there's a whole lot of stuff up here. But anytime I get a platform, I want to talk about Black people. Like, that's just the way I roll. And so I'm going to do that right now. Because one thing that has become incredibly prevalent over the last 3 years when people realize that racism was actually a thing, is the effect of racism on Black and brown people's health. Okay. And I have had so many experiences and encounters in the medical setting where the stress of being a brown person in the United States was their primary reason for showing up. And if we don't acknowledge that and recognize the link between stress that's been induced by life, by oppression, by isms, like we're not doing it right. And so again, like I'm using my platform because that's what I like to do and I can, okay? So how do we use like those functions I was telling you about to reduce health disparities and the inequities that may be caused by, again, those stressors like socio-political things like racism, oppression, loss of privilege and things like that? Well, we start again with definitions. Again, I never want to assume that we all understand the same thing. So real basic. The one thing I like to highlight, disparities or differences you can see. You can observe them, okay? So for example, we know at Cherokee Health Systems, I ran some data on all of our patients. We know that Black patients have statistically significantly worse hypertension control compared to our white patients. 59% of all of our Black patients who have a diagnosis of hypertension have controlled hypertension, compared to 79% of white patients with the diagnosis of hypertension who have controlled hypertension. That's a 20% difference, y'all. That's a disparity. That's a difference you can see, you can measure it. It's so big you can hold it, okay? When we think about equity though, that is like the root cause. Okay, equity is both a process and an outcome. The process is coming to find out why the heck is there a 20% difference in hypertension control between our Black patients and our white patients. The end result is removing the barrier that leads to that 20% difference. So that way we get equality if possible. So like everybody's blood pressure is controlled well, but you know, life, okay? And social determinants are the non-medical factors that get in the way. So another plug for the need to address not just the numbers that you get from, you know, your blood pressure cuff, but also the non-medical factors. In fact, we know it's those non-medical factors that contribute 30% to health outcomes. Social determinants of health contribute more than anything related to health behavior change or the medical things, okay? And so for us, we're dealing with the healthcare system, okay? So I want us to think about how, if we're thinking about the functions of primary care being contact first, being collaboration, being comprehensive, and being, you know, continuous, how can disparities show up that way? And how do we leverage the team to remove the barriers that contribute to the disparity so that way we're not ignoring portions of people's life and we're taking care of the whole person? So this is one of my favorite slides ever, and you'll have to give me like another moment of privilege because as an aside, this year has been like a hot mess for me, okay? So here's what it's been. In March of this year, actually February 27th of this year, I got a call that my grandmother, who was 92, had been having falls. And my grandmother raised me, like, that's my girl. So I hopped my butt on a one-way flight and flew home to Virginia. And I thought I was gonna go home and just like move her into my mom's house. But when I got there, I was like, oh no, I'm not leaving. Like I set up shop. And so I became her 24/7 caregiver. And I helped her as she died. I was her healthcare power of attorney. I advocated for her when hospice came in. I made sure that she said she didn't want no medicines. Don't give her medicines until she gives consent. No, I'm not going to crush them up and put them in her coffee. She said, no, I want her to trust me. So the answer is no. So I was there 24/7. She fell out of the bed because she was agitated and would rock and fall out the bed. So I slept literally at her feet or at her side. So if she started falling, I could feel her and lift her up, put her back in, or try to catch her, right? So me and her talking 2, 3 o'clock in the morning, either because she just fell out the bed and I'm like, girl, what you doing? Or because she's just wide awake and can't sleep. So I'm sitting there talking to her, and I called her Miss Loretta. And I was like, Miss Loretta, you know what I want to do? I want to plant a garden, right? So I already have plants. I have like 18 plants in this office right here and 30 plants in my office at work. Miss Loretta had like 30 plants in her living room. So I am her, okay? But I was like, I want to plant a garden. And she was like, cool, cool. And then she was like, well, you know, when you get a garden, I told her I wanted tomatoes. She said, you know, when you get a garden, you're going to have to cut some things off. And I was like, ooh, that don't sound too good. She was like, yeah, you're going to have to prune some things, because when you prune things, you strengthen the roots. And when you strengthen the roots, you allow the fruit to flourish and thrive. And when I looked at this picture, the next time I was doing a presentation, like I think I started crying in the presentation, because I was like, crap, Miss Loretta knew what she was talking about. Because even on this picture, if you look at the different roots, their words and their colors, okay? And if you look at the leaves, those colors match with the words and the roots at the bottom. But if I don't nourish and strengthen the roots, we don't get those leaves. If we're talking about access to health and human services, but I don't nourish that root, how are my people getting access to this integrated care that we're talking about? Maybe we need to do some pruning and get some rules and some policies out the way, so that way the orange roots get to grow orange leaves so people can thrive and grow. So my grandma was dropping knowledge when she didn't know she was dropping knowledge, because she was telling me in her way the importance of getting to the root of things and questioning and determining what roots are we nourishing and which ones are we ripping up and just destroying. What limbs and branches are we allowing to grow when we really need to prune them? Because without pruning them, we are holding ourselves and our patients back. And so when I look at this, I know it has lots of words and things, and it highlights the access to health and human services, but I think about this image in so many different ways, because we as humans, remember I told you that root causes and equity, inequity, it's both a process and an outcome. In our best intended efforts to help people, we're ripping up roots, y'all. In our best efforts to help people, we are failing to nourish some roots, which means the trees, the fruit that the tree is bearing won't get a chance to thrive. What do I mean by that? Clinic hours are oftentimes how we rip up roots. We make clinic hours around our availability and our, like it's convenient for us, okay? Some clinics have policies where if the patient comes 15 minutes late, they have to reschedule. That's ripping up a root, okay? Our healthcare system sucks, y'all. Like, I know this is recorded, I don't care. But our healthcare system as a whole rips up roots all day, every day. So it's up to us to prune. It's up to us to nourish the roots and the branches. That's on us as healthcare providers, as a team. We do it together. And I know this sounds fluffy and everything, but this is like my jam. I believe wholeheartedly that if we can address and identify those root causes, we can make some change, but we can't do it by ourselves, which is why you keep hearing me talk about the team so much, because we have to work together to get it done, okay? So when we think about like those root causes and the social determinants of health that have nothing to do with medicine, but they're the non-medical things, all this crap happens when we don't nourish our roots, or when we let branches grow unchecked without pruning them, okay? Lower life expectancy. And here in the United States, Black women, the maternal crisis, right? The morbidity and mortality crisis, the low birth weights, misdiagnoses, pain, like, you're not in pain because your skin is thicker, right? How the heck are we going to help people if we don't share the expertise about how ignorant some of this crap is, okay? And learning from one another about how to center the patient's needs, to not ignore what the patient's coming to. Regarding the maternal and fetal mortality, Cherokee Health Systems, I requested weekly data aggregated by identity markers, right? So ethnicity, race, language, zip code, blah, 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 for all of the measures that we track for the uniform data systems, which is just a reporting mechanism we do for HRSA, okay? For like 6 weeks in a row, I noticed that there was one group that had really disproportionately low birth weights compared to every other group in our entire system of 70,000 patients. And I know 70,000 patients can't birth, but roll with me. That's how big our population is. One group consistently had low birth weight. Y'all know what group it was, right? Black women and Black babies. That's a disparity. And I need to know what the heck is going on. Like, what is it about those social determinants of health? What root cause, what branch is going unchecked to contribute to this? And so again, leveraging my team, I've just started emailing folk. I know people in public health. I know people at the university. I know people who are OB-GYNs. I know doulas. I know lactation consultants. I was like, y'all, I need to talk to you. Like, my data tells me that my Black babies aren't coming out strong enough or big enough. Like, what do we need to do? So I got like a mini coalition, interdisciplinary coalition, because I just sent some emails. I was like, help me, because something ain't right. Like, I know it's not just our patients, but I see what's happening to our patients. What are we going to do about it? And so we've met a couple of times to kind of like look for strategies to address this. Like, were we entering data wrong? Do we need to do more touch points with, the birthing person throughout the pregnancy to make sure that the person is getting nourished and things like that, to address any stress levels they may have? But if I could change the world one low birth weight baby at a time, we'd be good. But I can't do it myself. So we've been working together. Okay. And that's just another example of like the equity again. You got to find what the barrier is and try to remove it. So a lot of people have seen this slide, but they only usually focus on the middle part, equality versus equity. But I want us to pay attention to the first panel and the last panel, because those are my two favorites. Some people were born, and I'm speaking from the perspective of someone who lives in the United States. I can't speak globally, but some people were born and they had every single privilege already. And it wasn't something they could give back. Like being white, cisgender, heterosexual, male, and Christian in the United States, for the most part, aren't things you can give back. Like, you just have them. And because you have those things, you have privilege. So that means you have a crate for every single privilege that you have. You don't ask for it, you can't give it back, you can't change it, but you got a crate, which puts you way above people who are born without crates or with only one crate. Okay. So you, with all your privileges and your crates, are chilling, watching this baseball game. It's so fun. It's so amazing. You got like the bird's eye view. Then the other person who might just have one crate, one privilege, he can still see the game, like still enjoying himself. But check my dude on the right-hand side. Can't spell crate. Not because he can't spell, but like because that wasn't his reality when he was born, when he came into the world. Like, he didn't have the privileges. And so you see that disparity, the difference, right? So we know the equality piece, give everybody one crate. Yay. But there's still one person who still can't see the game because, okay, you gave him a crate, so now he's not in the hole. He's on the ground, but he's still short. He can't see the game. So you're like, cool, I got another plan. Let's take the crates away from the left guy. Let's let the person in the middle keep his one crate, and let's give 2 crates to the second person. Now, everybody gets to see the game, and that's equity, giving everybody a little bit of what they need. But here's my question. Why do we keep adding crates instead of knocking down the fence? The fence is the problem. That's what's blocking people from enjoying the game. The fence is the root. Rip it up. Those are the roots you need to be ripping up. And I get really frustrated, and you hear my passion, hopefully, that in healthcare, in policy, we focus a lot on the solution. How many crates can we give people? How many crates does that person need to see the game? And I am asking all of us in whatever field we're in to push pause and say, do I need to be focusing on the crates? Or is there something else I need to be addressing? Why do we keep building ladders over the fence instead of working to dismantle the fence itself? Because the fence is what is getting in the way of people being able to enjoy that game. America 2022, be taller. That's it. Put that on a slogan, because that's what we're telling people. Just be taller. Just grow up a little bit. And that ain't solving nothing. So this is where we come in. Again, like, we are the workforce. We're the healthcare workforce. We work together. We have expertise that we get to share. And by myself, as much as I think I'm Superwoman, I can't knock down that fence. I need my people who know things that I don't know. I need the doulas that I outreach. I need the public health people that I outreach. I need the OB-GYNs that I outreach to help me, because they may see a different angle of that fence and say, you know what, there's a weakness right there, hit there. And I can see it from a different way. I'm like, no, hit this too. Together, we're going to get it done. Okay. So back to the question at hand, how can we use these, the functions of primary care to identify those barriers, to remove the barriers, to nourish the roots, to prune the unneeded branches? There are a couple things we can do, again, in the healthcare setting. So because primary care, integrated care must be comprehensive, we got to check ourselves. And I bet some of y'all thought I was going to say, oh, go to a conference and learn some things. No, look in your mirror, learn yourself. What are your automatic thoughts about people? Does that get in the way of you providing care in the best way you could? Are your biases about your own expertise limiting you from tagging in a partner who may know a little bit more than you do about a condition? Is your bias that, some things are just only in the mind? Is that getting in the way of you allowing the patient to benefit from another colleague coming in to provide expertise about what else could be helping or going wrong with the patient? Do we have stereotypical beliefs, right? Like all these things are things we need to check. I'm almost embarrassed to admit this, but I mean, I got to be real. So I am like the most feminist I can think of. Like, I will fight if I feel that any person that's a woman has their rights challenge, remove. Like, I'm a big fan of saying I'm gonna punch somebody in the throat. I've never punched anyone in the throat, but I just imagine it would feel fulfilling. Okay, so like, yay, we can do this. Like, forget the patriarchy, let's go. But there's this thing called an implicit association test that gets at implicit biases and automatic thoughts. So it's things like push, the button on the left if you think women are more likely to do this thing. Push the button on the right if you think men are more likely to do this thing. And they give really stereotypical tasks like wash the dishes, work outside the home, feed the baby, mow the lawn. And so in my head, I'm like, nope, anybody can do that. You don't have to be a man to do those things. Well, apparently my implicit bias is that it's women's work to wash the dishes and it's men's work to mow the grass. And I'm like, I'm so embarrassed, but it's how I was raised. So it's what's in my head. And when I push pause, I can check myself, but my automatic thought, that implicit bias is, oh yeah, obviously women wash the dishes. And I'm real embarrassed about that, y'all. But my point is this, I bet you we got some implicit biases about patients or about the role of mental health or about the role of medical health when it comes to taking care of our patients. I bet you we do. And I bet you without meaning to, those biases enter the room when we provide care. So that means we are not giving the best care we can, okay? When we are working on treatment plans, we got to make sure that we expand our scope. It's not just one thing. So many things are multifactorial. We cannot ignore the effects of discrimination and racism on health. One of the coolest things that I get to do over the next 2 years remaining now is I was awarded a fellowship with 2 colleagues from the Robert Wood Johnson Foundation. And when we applied to this fellowship, it was under the premise, they said, we know that racism exists. Do you know how powerful it is to read a call for funding that acknowledges that racism exists? Our funding request did not have to prove that racism existed. They said, we know that part. We are seeking calls for studies that are going to look at how racism affects health. Not does it, how. And we are really, really interested in looking at strategies to interrupt the processes through which racism affects health. And that just made my heart soar because I didn't have to fight it. I didn't have to prove it. I didn't have to try to convince somebody of it. We know it exists. So our project is interviewing staff and patients and just learning about their experiences in healthcare. Have they ever experienced any of the isms? If so, what do they think the effect of that is? What do they think we could do differently as a healthcare system to make those changes? Like we're assuming we know that all these isms negatively affect health. We want to know what we can do to stop it. As an organization, how can we do better? That's providing comprehensive care. if as a healthcare provider or team, we only take care of the things that we can measure with the lab, we're not doing it right. Okay, we are not doing it right. We have to work to expand our scope of practice. So yes, I do want you to go to conferences. Yes, I do want you to read books, but I want you to start with yourself in the mirror, okay? Consult, use the interdisciplinary team members. Don't do it by yourself, because there's so much that we can learn from one another and do together. And I will say this, like initially during the pandemic, when everyone realized that racism was a real thing, and when George Floyd was murdered on camera, I got really exhausted and tired of people saying, I'm just listening and learning. Okay, ain't you done? Like, what can you do with what you listened and learned about? So as healthcare team members, don't just listen and learn, or listen to me and learn what I'm sharing, or just listen to your patients, or just listen to your colleagues. Find ways to implement what you heard. That's how we provide comprehensive care as a team that addresses all those different things on the list of things that we can do together as integrated care team members. Okay. When we think about contact, we want to think about policies. You know I got some policy people on the line, so I want you to think about ways that as you move forward in your policy work, whether you're connected with a healthcare center or not, policies are root causes. They're upstream determinants of health. Policies are the roots that can either nourish or disrupt the growth of your healthcare tree, okay? No matter what discipline you're in, say yes as much as possible to anything that centers the patient, all right? And I'm not saying you gotta like make the patient your life, but when you're in the clinic, when it's your turn to be in the clinic, like, it's not about you. Leave your ego where it belongs, outside. It's about the patient, okay? And then evaluate organizational policies. Even if you may not feel like you have the power to change them, how can you make one tiny change that can help facilitate better or more accessible care for our patients? Competence, again, check ourselves. We have to be mindful of knowledge. Even as recently as like 3 years ago, I'm sure you all know about the study that assessed medical students, residents, and attendings, and the amount of people who believe that Black people don't experience pain the same way that other people experience because our skin is thicker. That's real stupid. But people sincerely believe that. And if that's a sincerely held belief, and you have a person who looks like me come in stating that they have pain, are you going to treat pain? Probably not, because you think my skin is thick and I can handle it, and I might be over exaggerating things. So yes, we do need to learn. We need to check our biases. We need to make sure that we're learning accurate information. Like, our skin isn't any different no matter who we are. Okay. I don't need a medical degree to tell you that. Like, my skin is the same as most of y'all's. Okay. We got to monitor burnout rates and provider well-being. And I'm mindful that the conversation regarding burnout has flipped to the point where it's almost our fault. Like, why aren't you engaging in self-care? Like, how can you take time to take care of yourself, instead of the system saying, we're losing our workforce. What can we change to keep them? And I know nobody has a magic wand, but we have to be mindful of the language we use when we talk about the rate of burnout. It's not the provider's fault. Okay. Like, they can't self-care this thing away. We need to make systemic changes. So again, my policy people, I need you to be listening to me. We got to push to get some changes made to the way that we do care now. I was reading an article, and it stated, like, if we are unprepared to provide effective quality healthcare to patients in a culturally responsive way, the patients may experience frustration with communication barriers, and the providers may be frustrated about patient dissatisfaction. So again, we have to be mindful of the thoughts that we have about the knowledge that we're consuming, so that way we aren't causing harm to our patients, whether we're addressing the mental health, the physical health, all of the above. We just want to make sure that we have appropriate knowledge. And then we want to listen to understand. I was speaking with a group of people who came to Cherokee Health Systems yesterday and today for a site visit. And one person stated, I've been really, really frustrated for the past, couple months or so, because I have this one patient who won't do anything I tell them to do. I give him all the prescriptions, I give him all the guidance, I give him all the advice, and he's still coming back with the same concerns. And I just don't know what to do. And I said, that's what the problem is. You are trying to fix it. I didn't hear you once ask the patient, what is important to them? Is this a problem that is of importance to them right now? Okay. What's their value? What's their desire? How motivated are they to even make the change? Are you just telling them what they need to do and getting pissed that they haven't done it? Are we allowing them to let us know if they understand what's up? Are we saying, okay, here's what I would recommend. What are you willing to do? But we can't get mad at the patients if we don't include them in the plan. So remember, they're the most underutilized member of the whole team. They'll tell you what they're willing to do. Okay. And it has nothing to do with the intervention. Maybe they're just not ready. And just because they came to the doctor doesn't mean they're ready to change entirely. Okay. And that's where having behavioral health on the team can sometimes be helpful. I have some primary care providers who express frustration very similarly. And I might say, you know what? Is that what they want? And they'll say, I don't know. I didn't ask. And I'm like, haha. That's why you mad. We don't know what the patient wants. Alrighty. We want to advocate for and with our patients, and we want to reflect, validate, and affirm. Our patients have been through some things. We have been through some things as a team, as a system, as a healthcare entity. Stuff has happened these last couple of years. This will sound real basic, but when patients show up, I like to say something as simple as, thank you so much for coming today. It may sound basic, but they chose to come. That means they prioritized something. I'm thankful that you found a way to get here. I'm thankful that you prioritize your health today. I'm thankful that you arrived for your appointment to allow me to partner with you today. Again, it's fluffy, it's corny, I know, and it affirms and validates the person's presence for being there today. Okay. But my very first supervisor ever in life told me, blessed are the flexible, for they shall not be bent out of shape. So all of what I said sounds amazing, awesome. Yay, let's check our biases. Let's work together as a team. How do we do this? This is cool. But again, the pandemic jacked us up. We had a workflow. We thought we could do it that way. And we leveraged team members where we could, right? We were like, we got this. We're not going to do it alone. We're going to work together. Sometimes you switch who sees the patient first, where you refer them first, doesn't matter. But then the pandemic happened and life happened. And so some of everything went left, but we still have to fulfill those functions of primary care, even though we feel like this sometimes. This is fine. This has been how I'm fine. This is fine. I have water. This is fine. Life is fine. But we want to make sure we pay attention to our workforce, because what I've said tonight is how we as team members from different disciplines can target and focus on the patient as a central feature of any healthcare system. So here are just a few things that I recommend as we're working together to blend the mind and body care together. A team of experts does not make an expert team. And sometimes that's real hard to swallow, especially when you work together on an interdisciplinary team, because one person's like, nope, I got this. I know more than you do. I have an MD, not an MPH. And yes, I know I probably stepped on some toes. Doesn't matter. A team of experts does not make an expert team, okay? We also have to remember that the patient is an expert in their own lived experience. We cannot negate their lived experience when we engage in care planning for them. Okay. So experts can check the box, yeah, I checked for this. I gave that diagnosis. I gave that prescription, blah, blah, blah. But an expert team works well together. They communicate, they coordinate, and they cooperate with one another. One is not more important than the other. Okay. Because again, the patient is centered. Another way we can make sure we focus on the workforce so we can do this work, in addition to checking the ego and trying to find an expert team versus trying to emphasize your expertise, know your role and but be okay with fulfilling other functions, even if that's not your role. So this is one of my favorite slides ever. You know, like we got old dude falling out of the ambulance while the ambulance is driving away. So here's how I imagine this scenario went. Ambulance driver was like, cool, we got the patient, I'm gonna go ahead and get in. And stretcher pusher and door closer was like, cool, we got the patient, I pushed them in. And then they just got in the car because they got excited. And then they start driving, and then like car drivers like, did you do your job and close the door? And door closer was probably like, no, I forgot, I just pushed the stretcher. But door driver or car driver never once said, let me help the stretcher pusher, like I'll get the door while you push the stretcher. They were like, nope, my job is to drive the car. And that's why we got folk falling out the ambulance now. Do not get so stuck on the fact that you're the ambulance driver that you can't close the door, okay? There are functions to take care of the patient as a team, multiple disciplines. Just because you got a role does not mean that's the only job you can do, okay? So you want to be mindful of your role on the team and keep in mind that you're a team, because the patient is the one we're caring about. And again, some people get really frustrated when I talk like that, because like, that's not my job. Yes, it is. Patient care is your job. Figure it out. Okay. If we want to keep the morale going here, just some basic things that we've done at Cherokee Health Systems. Again, real corny and very like helpful. We have a bi-weekly newsletter that goes out to the entire staff. We have about 750 employees, and we name people. We're like, hey, guess what happened? So where this says to a team that worked like a symphony, we told a story about how maybe 3 or 4 different team members, none of us work in the same clinic, FYI, we have 23 clinics. We're sending emails and phone calls and like secure messages to help one patient get from one clinic down to another clinic. And we shared this with our CEO, Dr. Katherine, and she was like, it worked like a symphony. And so we called out all the team members who played a role in that. And it may seem cheesy, but like 750 people get to hear that you work like a symphony with your team, bringing your expertise to work as an expert team. Hit out the park. So here's an email that I got. I believe that's what we call a grand slam. It was awesome. I love you guys. And then during a training, when all of our behavioral health providers, like over 100 of them were up there, I called out the one person who took the initiative and kept it moving. And I was like, I just want to call out this one person, because we wouldn't be here if this person didn't see the need and say, you know what, I'm going to do it. Okay. And then lastly, 3 good things is another thing that's helpful, because again, I'm not assuming that this work is easy. Again, if we keep in mind all the things we've dealt with over the last couple of years, we want to make sure that we acknowledge the good. Okay. So I told you all, like when I started, like 2022 has sucked for me, but here's my gratitude. I don't look like what I've been through. And it's moments like that that I got to write it down. I don't look like what I've been through, like literally. Y'all can't see what I've been through right here. That's my gratitude. So even when I'm feeling frustrated, or even when I'm feeling like I can't move the mountain that my patient needs me to move, or even when I'm feeling like my team is not listening to me because they think they know more than me, I don't look like what I've been through. And we did an initiative across our system where we just left out little cards that said 3 things. And we asked people to do this every single day for a week and to comment on how their mood was. No, it didn't change the complexity of the patients. No, it didn't change the scheduling. No, it didn't change the reimbursement process. No, it didn't change the healthcare system as a whole. But we said, for 1 week, what are 3 good things that happened to you, or what are 3 things for which you're grateful at the end of every day? Don't do nothing else with it. Just write it down and keep it moving. People reported feeling more content and more willing to go the extra mile to take care of even the most complex patient. And we did that. And so I'll leave you with that, because I know I've given you a lot. We work hard to take care of our patients. We can't do it by ourselves. Racism exists, and that's one of the things we need to be addressing in healthcare as a team. But don't forget to take care of you. Okay.
Thank you so much. Can we give a in-person round of applause for those who are there? And then also for those who are virtual, can we please give a round of applause? Dr. Winford, first, let me say thank you to you for your commitment to Meharry Medical College. Because as you said, you don't look like what you've been through, but you have just been through a significant surgical procedure. And to have you on this Zoom with all smiles and on fire, I know you. We go way back.
We do.
Fire today. And I just want to say thank you. We honor you. I know Dr. Matthews Juarez is on here, but we would be remiss if we didn't pause and just say thank you for being here.
Yeah. Thank you for having me.
Yes.
Thank you, Dr.
Yeah.
Winford.
And thank you for that awesome
Thank you.
presentation. So what we want to do now is open up with questions. If you have questions, you can put them, you can unmute, you can put it in the chat. But Dr. Winford, the chat is blowing up tonight. The room is blowing up tonight, and we are just excited. So who has any questions for Dr. Winford? I see Dr. Matthews Juarez has unmuted, so we will let Dr. Matthews give the first word.
Well, I'm just so appreciative of the candor, the approach, the humanness, and the stories. It is really through that process that we learn about integrative healthcare, but it's through that process that we get to put ourselves in the other person's shoes and get rid of some of the biases that we have.
Mm-hmm.
And it doesn't matter what color you are, how old you are. I mean, it just means that you care about the person that you see in front of you. But most importantly, Dr. Winford, is that real appreciation for self. And, I think that those of us who can identify with you buying a one-way ticket to take care of your grandma. It's just an incredible tribute to the work that you do for others. So we thank you. We feel privileged and honored again to have you. Maybe it's the fourth time, but we can see 5, 6, 7, 8, 9, 10 times. And we will have you. So thank you again, and we appreciate you.
Thank you.
All right, Dr. Winford, looks like we have a question in the chat, and then Mr. Fleming, if you get one that's in the room, just raise your hand on the screen and I'll switch to you. But the first question comes from Melanie Woods Williams. How do we encourage others that we work with who have obvious bias that are negative?
Yes. My approach may be different than others because obviously I don't have a filter, but I'll give you an example. So right now, where we work, we are really doing a much better job at meeting needs of people who are gender diverse, as well as people who may not be heterosexual. They may have men who have sex with men, whatever the case may be. We're doing a really good job of doing that. And not everybody gets down with that. Like, they will choose to say that they don't want to provide care for someone or use the correct pronouns for a person, or they may dead name a person. And instead of me trying to push to that person, because again, if I'm not sure if you all are familiar with health behavior change, but the more we tell somebody to do something, the more they're going to tell you why they're not going to do it. So instead of me saying, you're ignorant for doing that, I model. So when that person comes in, I'm really extra about using their chosen pronouns. I'm extra about using their name. And notice I'm not saying preferred pronouns or preferred name. It's their name, it's their pronouns. I use them when I can. When I'm providing feedback and working with the team, I am explicit about naming, that person's pronouns and names. And that's me modeling. I'm not telling someone what they need to do, what they could do, what they should do, but I'm showing you what I'm choosing to do. And hoping that you're listening. Now, I will absolutely tap you on your shoulder if the modeling is not working, because that's just me. But I try my best just to model what could be done differently. I also take the really curious perspective, like, can you tell me more about that? And just play dumb. and try to get someone to explain, the bias that they have. And oftentimes they can't do it. And I'm like, really interesting. I'd love to learn more. Tell me. And just lean into it. And they start stumbling. And I was like, okay, cool. But again, I'm never going to challenge you like outright unless it's like really explicit, because I still got to work with you and I want you to receive the information that will help you help the person. But yeah.
Thank you so much. Are there any other questions? I'm checking the chat. Are there any questions from those who are on site?
There's
All
a
right.
hand raised.
Okay, all right. Please unmute Mr. Fleming if you have someone there. All right, welcome. Tell us your name and then your question.
Hi, thanks for being here today. So my name is Tayo Abdulrazak. I'm a fourth year medical student here at Meharry Medical College. So my question is, I want to do psychiatry in the future. And I was wondering with COVID-19 and things kind of growing more digital and more emphasis on telehealth, have you seen a decrease in the disparities or access to health with communities of color seeking mental health?
I can get on the soapbox for a lot of things, but this was my passion, particularly when the pandemic first started, because Medicare, when we first started transitioning to telehealth, would only reimburse if we had the face-to-face component. Who's the most likely recipient of Medicare? 65 plus are people who are disabled. So people like my grandma who have never used a computer in her life. And we were not gonna not provide care to people just because we can't get reimbursed. And we weren't gonna like tell somebody, oh, sorry, your insurance won't let us see you because we can't do, Zoom or something like that. So we advocated the heck out of everything. So at that time I had this wonderful idea. I was like, you know what, I'm gonna go back to school in the middle of a pandemic. I'm just gonna get a whole nother degree because I woke up and decided that. Don't recommend that. But I was in some classes with some professors who worked on the Hill during the Obama administration, implementing the Affordable Care Act. And I just happened to share in class one day. I was like, I had a patient I spoke to, and she canceled her appointment because she didn't have Zoom and she didn't think she could be seen. And she was a Black woman. And I was used to speaking to her, seeing her regularly, but she canceled because she didn't have Zoom. And I was like, I'm mad because she shouldn't have to choose between getting her health care and having technology she's not comfortable with. And so next thing I know, I get an email from my professor. She's like, talk to this person. In the course of like 2 weeks, I did an interview with the Boston Globe. I wrote an interview for the Hill. I did an op-ed like with the Tennessee Primary Care Association. I was cited in some random senator's like testimony on the Hill. And they expanded like the Lifeline minutes for people who had phone. They started working toward removing the face-to-face component for telehealth because absolutely our people were being disproportionately affected by those random rules and policies. Like you don't need to see people for them to report their symptoms to you. Now, of course, you need to check some things, right? Like that's a given, but like you don't need it for every single appointment. And we were limiting people's ability to access care because they couldn't access technology. And maybe they couldn't afford technology. A lot of my patients have cell phones, but no data. So even if they had a cell phone, they couldn't get on Zoom. Does that mean they can't have care? No, I refuse to accept that. And so it absolutely negatively affected people of color and their ability to accept and access care. But I'll tell you what, the audio only thing is a game changer. Our telehealth kept rate increased by 2,000% when we went to audio only. More people than ever have been able to access care because we have the phone version and because the Lifeline, also called the Obama phone, has unlimited minutes now as opposed to 200 minutes and unlimited text. So yes, they couldn't get the help they needed. But like, if you find something, even in med school, if you're like, this does not make sense, say something. Because there might be somebody who's going to send you an email and say, talk to this person real quick. Because like 5 interviews, right, quick, fast, because I complained about not being able to take care of my patient. So
Thank
if
you.
see something, say
Thank
something.
you.
All right, you have another question. I saw Melanie Woods Williams' hand raised. So I'm going to ask that you unmute and ask your question.
So what I was going to say is, how do we see a lot of things that happen with our Black males. How do we erase that stigma that there's mental health as an underlying mental health issue and help them? Because in our community, and I've seen this a lot, our Black men can be anything but crazy.
I know
They can-
that's right.
Yes, they can be considered anything but that. But usually there's some kind of underlying mental health issue and they're embarrassed to even get help.
Mhm.
So how do we fix that problem?
So this is going to be one of the hardest responses ever because I don't have my magic wand. If I had a magic wand, I would make the workforce reflective and representative of the people seeking care. So if I wanted to help Black men access care, I would magically create Black men in the workforce if I could. Now, I know I can't do that right now. What I can do is identify pathways through which people who look like the patients who aren't getting the care that they need are being trained to provide that care. So colleges and organizations like Meharry Medical College, other HBCUs where we have people who have interest, but maybe not a mentor, maybe not the connection they need to enter into the workforce. So I'm starting upstream with that, right? Like we got to build the workforce in order to meet the need. For the people that are coming in now, I think we have to remember their humanity. And I am very quick to try to find something, meet them where they are. If they don't want to say depression, I'm not going to use the word depression. If they want to say stress, cool, let's talk about stress. I try to find their value. A lot of people, the value might be, the value might be taking care of their family. So I might say something to the effect of, how is your stress getting in the way of you being able to take care of your family the way you want to? Is there anything we can do differently so that way you can take care of your family the way you want to? And I know I can't change the world for you, but maybe we can find one thing we can do differently, so that way you can take care of your family the way you want to. But try to reframe it in a way that doesn't stigmatize, that really amplifies the thing that gets them moving day to day. Sometimes just being explicit, like I have had appointments with Black males where we were each crying because I was like, we need you.
Mm-hmm.
Like the world, the United States, we need you. We've seen you die on TV. I know that I've never walked in a Black man's shoes, and I'm married to one. I am terrified when he leaves at night because he might not come home, and I'm open and honest with that. I will tell people, I know you're tired. I know you're scared, and we need you. So what can I do to help you? I can't change everything, but we need you, and I need you to hear that. How will you let me help you? Because we need you. And again, I got a Black husband, a Black father, a Black brother. Like we need our Black men, and they are literally being murdered in our faces. And I acknowledge that. I don't sugarcoat it or nothing. And I say, I bet you scared. And there's nothing wrong with that. That doesn't make you weird. Will you agree to come back? Because we need you. And I think you just got to be real. But again, there's no real short-term solution to that shortage. I mean, we got to build the workforce and we just got to meet them where they are. I will use whatever language they will be acceptable to listening to. But that's real talk right there. Oh my goodness.
Thank you so much. Thank you.
Thank you so much. Thank you all for those great questions. At this time, our Q&A continues. If you have a question, please, you can use the raise hand feature or you can type in the chat. Are there any questions for Dr. Winford?
There's a hand in the room.
All right, please, we'll take your question. I'm going to press and ask that you can unmute, please. I don't see it, Dr. Winford. The screen is.
Okay, I thought I saw Mr. Fleming's hand raised, and then the camera went off.
All right. Are there,
Maybe they changed their mind.
maybe
That's
they
all right.
changed their mind. All right. Any other questions? So we're going to launch the survey. I would love to hear from you, Dr. Winford. What does success look like? Like with all the work that you're doing, for you to say, I've got success, what does that look like? And then you see, we do have a second question in the chat, which asks, what are you reading? So what does success look like? And then what are you reading?
That's the book I'm currently reading.
Okay.
Girl. I love it. It's a book about essentially being a Black woman globally. And essentially like fighting the narrative that you got to be Superwoman. Like it's okay to take your cape off. So I'm reading that. I am also reading Nothing Burns as Bright as You. I read like at least one book a week, mostly multiple books, but because I've been on medical leave, I've read like 3 books a week, done some puzzles. So I'll put that in there. Nothing Burns as Bright as You. I'm reading that as well. What did I just finish reading? Goodness, I can't remember, but like there's always something that I'm reading or listening to. And how do I define success? Gosh, like it's hard because I don't really define it in material ways. Like I've never been one to take a job for money because I know my needs are going to be met. I'm not stressed about that. Success for me is when I can go to sleep with peace, knowing that I did all I could, whatever that is. Like my peace is there, even though I did the work. Like I want my work to speak for me. I don't want to have to brag about it. I want my work to speak for me. And I think that's a definition of success. When my work speaks for me and when I can rest peacefully at night when I go to sleep, because I know I did the right thing.
Wow, that is a powerful note to end on. There's not much else that can be said after that, Dr. Winford. So a couple of things, housekeeping. The survey is in the chat. We definitely want your feedback as we continue to evaluate our programming so that we can continue to have dynamic speakers like Dr. Eboni Winford. So if you would, please click the link in the chat and take a few moments to complete the survey. Now, if you are on site, you also have a link to the survey, and we would ask that you complete the survey at this time. Dr. Winford, thank you so much. I am sending a virtual heart your way. Thank you for being you and for all that you do. And listen, as Dr. Matthews Juarez said, this is not your first time. But we know this will not be your last time. And we're going to have you come back. So I see that our fearless leader has given you a heart and unmuted.
I know, and turn on the camera.
And turn on the
What
camera.
do I do? Oh, this pleasure.
Wait, here we go. We have a pin.
Now, Mr. Omar needs to turn off his camera because this is a professional meeting, Mr. Omar. So we thank you so much for attending, but turn your camera off. The excitement here, thank you so much. The excitement here is that Dr. Winford is a part of our teaching team, and we send our residents, BHWET residents, out to Cherokee. Dr. Wallace is on the phone tonight on the session tonight, and we really appreciate all that you're doing for us to make this integrated care seminar work. So thank you again, and we look forward to seeing you even more as we come back into our school setting
in real life,
and hopefully see you again. You're absolutely wonderful, and we thank you. That's an old gal to a young gal.
Well, then that's the highest honor.
If I may say something, please.
I love it. Was there a question?
Dr. Brown,
Yes,
sorry if I may say something. I am so
yes.
sorry. I didn't know I was still on camera. I'm so sorry about that, Dr. Ores. And also, I'm currently rotating through BWET right now through CHC, and it's been a great learning experience for me.
Wonderful.
Yeah, I actually saw Dr. Winford today, but I didn't know who she was. I was working with one of the doctors, and she came in and she was speaking, and I just reached out to my wife now, and she said, "Oh, that's a Dr. Winford." I said, "Oh, I think I saw her today, but I didn't know
Yeah.
her." But thank you for this lecture. Thank you very much for all you guys are doing with
Thank you.
our rotation.
And thank you for your generosity, Mr. Dr. Omar. I sent you a note, so I knew you didn't know that you were on camera.
I'm very sorry, man.
Not a problem. I
It's
knew
okay.
you didn't know.
Well,
All
thank you
righty, back to
again.
you, Katherine.
Oh, you are welcome. It's an honor to serve as your moderator and always saying thank you to the one that I report to. Thank you, Dr. Matthews Suarez. So at this time, I will turn the program back over to Mr. Ross Fleming III for closing remarks, and just thank you all for coming. And please tweet something that you heard, because Dr. Winford had so many quotes that we could have tweeted. I was writing them down. So please use our hashtag PCTCOP and share the message with others. Again, it was a pleasure to serve as your moderator. Have a great day, everyone. Mr. Fleming, I'll turn it to you.
Thank you, Dr. Brown. I'd like to
Thank you, Dr. Brown.
Dr. Winford, for accepting my invitation. First of all, I'm so grateful and appreciative of you as you're recovering, that you would take your time out and come to speak to participants. I really love that. And hopefully next time you'll be really recovered and we're gonna have a better time. The day was just so wonderful, but I know I can see your passion and I can see the compassion you have for patients. So I really want to have you back again at sometime soon. If we can.
I'd love it.
Thank
This
you
is like
so
my
much.
second home. I've adopted myself.
Oh, we adopt you too. So,
I adopted myself. so.
okay. But if there are any other questions right now from the audience here in the room, are there any other questions? I want to thank you guys for being here with us today as well, taking your time out. So for being here, and for everybody out in Zoom land, I appreciate you as well. I did put the survey out in the chat box. If you would please, we have a lot of people online right now. If we should have at least 40 answers, survey answers after this program this evening. So thank you all for joining us this evening, and that's it. Thank you so much for being here tonight. Thank you, Dr. Matthews Suarez, as well.
Not a problem. Happy Tuesday.
Happy Tuesday.
Happy Tuesday.
Thank you, guys.
Bye-bye.
She's gonna wait. Okay.
All right, I'm gonna stop the recording.
That's why some could have told the other aides go.